All right, welcome everybody to the Society of Thoracic Surgeons Adult Cardiac Surgery Database Quality Improvement Series. And as Carol alluded to, we are going to wrap up our decreasing ventilator times. And then we're going to talk a little bit about our next project coming up. On the call from the STS, we have Emily Conrad, Carol Crone, Banu Yatsi, Paul Meehan, and Melinda Offer. And we will go ahead and get started. So first, just welcome and introductions. We already did that. We're going to review our vent times data and kick off our next project, which will be around decreasing blood usage. So quickly, some important dates for adult cardiac. Today, October the 16th, is the ACSD Quality Improvement Series. Next week, on October the 24th, is the AQO ACSD Hot Topics webinar. For those of you who attended AQO or purchased the virtual platform, you'll be getting a link to this meeting, which will be next week. November 6th, the ACSD monthly webinar. November 20th will be the ACSD Quality Improvement Series. November 22nd is Harvest Close. That will be Harvest 4 data through September 30th, 2024. And then November the 26th, the Harvest 4 opt-out ends. All right, so we're going to review our event times since we started this project, beginning with Harvest 1 2023. This is where we were at. Our average vent time, average hours, 15.3. This is for isolated CABG. And you can see we have highlighted here the 6-hour mark, the 12-hour mark, and the 24-hour mark. The goal is to increase the time on the left side and decrease the time over here all the way to the right.
Yeah, make the left side further away from the green vertical line, more towards the first green vertical line. You want to scoot that into the right? It's when we do that, that means we're gonna have more sites that are extubating at the 6-hour mark or before the 6-hour mark. And then we want to make the panel all the way to the right. Where those two red lines cross, we want to make that little square there smaller. That side, we want to scoot way over to the right. So that means we have less sites who are extubating patients over 24 hours or more. So those lines that cross at the time and the sites where you have the average hours. So I should have started there, I guess. And maybe you did already, Nancy, but that first green vertical line, it falls just about at the 31 mark. And you can see the first line it crosses, that's that 6-hour, the first horizontal line it crosses, that's that 6-hour mark. And that's what we've heard, getting patients extubated 6 hours or sooner is really good for improved outcomes and decreases the chance of morbidity after certain morbidities after surgery. So you want to see that population grow because that means that those patients are having less risk of a bad outcome. So that's how you're looking at that. Okay, sorry. Go on.
Oh, thank you.
Mm-hmm.
So this is where we were for Harvest 3 2023. A little further into the project. Looks like we moved the needle a little bit over here on the left side with the 6-hour mark. And then decreased it a little bit to the right, which Carol was explaining earlier. So for Harvest 3 2023, our average ventilator hours were 14.42. And this is for isolated CABG. So here's where we are now. This is Harvest 1 2024. This is all sites average ventilator hours for isolated cabbage. We have a good portion of our sites getting patients extubated in less than 24 hours and a good number in less than 12 hours. So that's great progress there. Do you want to say anything about this one, Carol?
No, I think we're going to see more. One thing we didn't take out were those outliers with the very high numbers. And sometimes that when you look furthest to the right there, you'll see some sites peaking um, at 100, average vent hours of 100. And those are likely the outlier sites. Maybe they have a small case volume and they had one patient that stayed on the vent for a long time, making their average higher. So uh, I wouldn't pay too much attention to those. It's probably more like the 64, 68 being the higher end of the averages for sites.
And this is our mechanical ventilation hours versus time. And then this again is for cabbage. And you can see back in 2022, the first 6 months of 2022, where we were. Then the next 6 months, so that's quarters 3 and 4 of 2022, are the orange graph. Then in the gray, quarter 1 and quarter 2 of 2023, you can see that the vent times went down here. And then here at the end is 2023 quarters 3 and 4. And you can see that we've made great progress here. So we were as high in 2022 as 17.1 hours and as low as 13.8 hours in 2023. So progressing in a great direction there.
Yeah, that I just want to talk about that one a little bit,
Oops,
and show you how, talk about how we pulled that data out. Where'd it go?
hold on.
There it is.
There it is.
So Nancy talked about it looking at each quarter, and then where we had started the project was around, um, we started looking at the first 3 months of 23. I think we've been doing this project a little over a year and a half now. And you can see um, it's probably been something within the cardiac surgery quality environment to decrease vent times for a long time prior to us starting this project, of course, at a national level. So you could see a slight trend of the numbers going down, but you could really see a difference when we did start this project in March of last year, April of last year. We started it quarter 2 of 2023. And you could see since at that time that the counts have really come down. There's p-values. I don't know if he included p-values here on this one. We'll have to ask him. This note was from previous. I'm not sure I see the p-values here. Um, but when we looked at this last time, the p-values for Harvest 3 2024 or 2023 compared to Harvest 1 2023 showed a significant decrease, statistically significant decrease. So we'll report back on that on our next webinar. But from what it looks like is that we've all been doing really good on a national level, and the work that and effort we've put in has made a significant change in the mean ventilation hours for our patients. So good job.
Right, this is just, we divided out the sites by high volume, moderate volume, and low volume, just to get a better look at our times. This is where we were Harvest 1 2023 for our high volume sites. This is our high volume sites for Harvest 3 of 2023. And then this is where we are now, Harvest 1 2024. So we have less number of sites that are greater than 24 hours. So that's great progress there. The average vent time is 14.84. So this is taking a look at our moderate volume sites. Here, Harvest 1 2023, that average vent hours were at 15.3. And here we are at Harvest 3 2023. And then here we are now, Harvest 1 2024. As you can see, we have a good portion here that are less than 12 hours. That's great progress. Looking at the low volume sites, we started out at 15.3 for the average vent time. And it looks like a good number of sites there on the right that are greater than 24. This is actually Harvest 3, 2023. Oops. Carol, do you have that low volume?
Yeah, hold on one second.
If you can share, I'll let you take over for that one slide.
Okay, hold on one second. Oopsie. I got too many things open here. All right, there we go. And then the low volume slide. Oh, look at that. The dog is still there. Hold on one second. I don't know why it's not. Okay. This is Hank and I watching TV. Hank in Bristow's and Talladega on their brother's bed. And then Hankster in Bristol and Bristol's pooper. All right, let me see if I can. I don't know what's going on and why it won't let me go. Hold on. Oh, cancel. That's why. Okay. All right. So we're looking at the low volume side. That's this one, right? That this one, Nancy?
I
Where we are at?
I think that's 23. Harvest 1, Harvest 3.
Oh, I don't know what happened to it. Well, anyway, it looked like there was really great progress with the low volumes. We'll update the slide deck before we post it. We just had a hard time getting the slides in there, getting the lines added, and making sure it was all good to go before the call. But we'll get those added in there. And Nancy, I'm gonna let you take it back over. I'll put the dogs back on so you can all appreciate those guys a little bit more. And I just want to mention Hank and Bristol are 2 and Talladega still 1. And he's learning how to be a good brother. And Bristol's pooper. All right. All right, there you go. Thanks, Nancy.
Thank you, Carol. All right. So next, we're going to look at extubated in the OR case counts. This is for cabbage, and this is over time. This starts in January in 2021. And you can see that by December of 2023, we were trending upward with getting our patients extubated in the OR.
And what I thought was what Nancy, what you and I both thought was interesting here is if you look at the last quarter, I guess, of each of the years, and maybe not so much for 21, but you can definitely see it in 22, and then you'll see it again in 23, is um, there seems to be a trending drop and then it gets better. And then as you get that back to the end of the quarter of the year, there's a drop again. And Nancy mentioned something at her site that Nancy, do you want to share your feedback on that? What you
Yeah, I
noticed at
was,
your site?
yeah, yeah. So when Carol and I were looking at the data, it reminded me of back at the hospital where I used to work. We were looking at our vent times, obviously, along with the rest of you. And we noticed that in October, November, actually the whole last quarter of 2023, we had, you know, decreases in all of our outcomes, but we weren't getting as many patients extubated in the OR. Our vent times weren't as good as they had been earlier in the year. And we did notice that we had gotten an influx of, I don't know, rather really urgent or emergent cases toward the end of the year. So I didn't know whether that was the same thing that had been happening to everyone. Toward the end of the year, you were seeing some cases. Maybe patients had been putting off their treatment until the end of the year, and then had gotten worse and didn't have as good of outcomes as the patients had earlier in the year. It was just a thought, an
Yeah,
observation.
that was pretty interesting. But what's despite even the ups and downs, you can see that the steady rate over the last 3 calendar years has been increasingly trending better to where we're getting more patients extubated in the OR, which is great.
Yep. Here is prolonged ventilation, the STS average for CABG. And so you can see this again is over time. This goes back to 2017 up to December of 2023. And you can see that prolonged ventilation times have trended downward as a whole, STS as a whole. So where we were, 7 to 9%, we've dropped down to 5 to 7%, like hanging around 6 or so. And you can see that over here
Yeah,
to the
that's
right.
phenomenal.
Yeah. So all of our efforts to decrease vent times have really impacted prolonged ventilation as a whole, which I think was the goal of the project. So,
Woo woo. Good job, everybody.
yeah. So that said, we did it, and congratulations to everyone who participated in our first QI project.
Yeah, I'm really proud. We should all be really proud of ourselves. We did a great job and worked as a national team to make significant changes for patients and healthcare overall. Hopefully, we can do some more formal analysis looking at this data and the impact that we've had on a national level using the STS national database. And I just want to say congratulations to all of you for doing an awesome job in improving the outcomes of cardiac surgery patients and making our healthcare a better place in the United States and all over.
Yep.
And then, Nancy, what's
And then
next?
what's next? So we have another project coming up and just wanted to take a second to kind of go over why we're doing this. Um, so the whys of why we're having, quality improvement projects nationally. We want to show the value of the database. There's more to the STS national database than just getting reports. The data that that you all collect is very valuable, and it really does help impact patients all over the United States and the world. So we also are doing this to make the data more actionable. Um, yes, you get these reports, but what are you doing with them? How are you making things better at your sites? And it's also to highlight just how important each and every one of you are when you are abstracting the data for the database. This data gets used in so many different ways, um, through research and, projects at your own sites. Um, and really what it comes down to is improving patient outcomes. Um, we all want the best for the patients that we serve. So using our data, working hard and abstracting good quality data to improve the health care of all of our patients is of the utmost importance. Plus, we want to be a part of a national team effort to improve patient outcomes. And this is a Carol quote. It's awesome to work together towards something. So that's why we're doing it. Um, that's the why for the quality project. And our next quality project is going to be around decreasing the use of blood products. And so why did we choose blood usage, decreasing blood usage? Well, um, blood transfusions, while sometimes they're, or most of the time when we give them, they're very beneficial for the patients, but they're not without risk. Um, and they're also can be very expensive. Um, so we want to be good stewards of resources. So some of the risk for blood transfusions and reasons why we would want to decrease blood usage are infection. Infections nowadays are pretty rare, but they can happen. Um, patients can receive or patients can contract bloodborne illnesses from blood transfusions, such as HIV, hepatitis, or other bacterial infections. Another risk for receiving blood products and a reason why we would want to decrease the use of blood are immunologic reactions. So these are things like febrile transfusion reactions, anaphylaxis, antibody mismatches, hemolysis, organ injury, transfusion-related acute lung injury, TRALI. That's a
I've
pretty terrible thing for
so
patients to go through.
I had a patient in the CVICU and they were getting blood, and all of a sudden I came in and I was listening to their lungs. It was the most horrendous thing. It was absolutely scary, and it was a trolley event. Was never really expecting that, but it happened.
Yeah,
My
and it
goodness.
does happen, and it's very bad for the patient. It's a very bad outcome, and it leads to lots of hospital days, lots of other problems, and unfortunately can lead to mortality. So we don't want to see that.
Yeah.
It's very scary, like you said. Um, Other risk of blood transfusion are transfusion errors. These can be donor related or care team related. Just errors having to do with patients getting the wrong blood, donors not going through the correct screening processes, those kinds of things. And then death. Their studies show a correlation between perioperative blood transfusions and higher mortality rates. And finally, length of stay. Blood usage impacts the length of stay. Patients that receive transfusions stay a little longer. They may have had one of those immunologic reactions or an infection or just basic volume overload. But at any rate, patients that receive blood transfusions tend to stay in the hospital a little longer. And we all know that when you stay in the hospital for a long time, it increases the cost. And so decreasing blood usage impacts your hospital by way of cost. If we can reduce the use of blood, then we can reduce the cost to the patient and healthcare costs in general. So that's why we're doing it. We want to try and kick this off at our next call, November 20th, our next quality call. And then the process for defining for our quality project, we want to define it. So we know that nationally, we want to decrease blood usage intraoperatively and postoperatively in the CABG population over the next 12 to 24 months. And we're going to measure this using our STS harvest reports. So for
Great.
harvest two, did you want to say something,
I
Carol?
was just gonna chime in about intra and post-operative and total blood usage. So on the IQVIA dashboard, when and we can look at that. I think we probably will have time after we get done here, but we'll show you where to find that on the IQVIA dashboard under the benchmarked report, so you can see both the intra, the post, and the total blood product usage. Thanks, Nancy.
Yep. And so the current benchmark rates for those intraoperative blood use, the current STS rate for that is 24.52, and for postoperative blood use is 27.89. So we want to be better than that, so less. Then we're going to analyze. We'll use the harvest reports, and you'll use your local data. Sites will implement processes to decrease intraoperative and postoperative blood use, and we will provide education and support for the processes. We want to engage site leaders who've already initiated blood conservation projects and decrease their blood usage to help us provide education on webinars and be available as resources. And finally, we will track to see improvement nationally. So if your site has had success implementing a blood conservation project, we invite you to share your story with us on an upcoming ACSD QI series webinar. We ask you to engage your stakeholders at your sites. We want improved patient outcomes. We want decreased risk of bad outcomes, decreasing cost and resources. And also, all of these things will improve your star ratings. If you are able to institute quality improvement projects at your hospital, we would love for you to participate. And if not, please share this quality series with your quality team at your site and ask them to join on our webinars. Again, we don't want anyone left behind. We want everyone to be able to participate in our upcoming project.
Great. Though I was just going to say on the first box, if you have, we already have, I think, a site or two lined up who have instituted QI projects. We'll invite the presenter who shared their abstract with us at the AQO meeting on blood conservation, improving outcomes. But if you have implemented a blood conservation project, it doesn't have to specifically be for CABG patients. If you've instituted at your hospital for overall any type of blood conservation project, we would love to have you come on to our webinar and share with the audience how you did it, what you learned from it, quick resources that you might have for sites, maybe easy tips and tricks similar to when we heard about one of the larger sites, Johns Hopkins, how they instituted something that was so easy, but cost a few pennies, and it saved them hundreds of thousands of dollars and improved their vent time. Those types of tips and tricks and just your feedback and your quality improvement project to share with the nation and help us all perform better and care for the patients better. So if you have something like that you're willing to come on to one of our webinars and share, please reach out to me and Nancy, and I'll put our emails in the chat box, of course. But we need you to help us. We need you to work with us on this too. Thanks.
All right. Thanks, Carol.
I told Nancy to get out her soapbox. Oh, look at that. There's our email addresses, just like that. I told
How
Nancy
about
to
that?
get out her soapbox, but I think she's still I don't know if she took me for real or not. She thought I was joking. But I feel like we're on a soapbox calling for everybody to help us.
Thanks for getting on your soapbox, Carol.
Yeah. We're all passionate about it, making patients better, patients' surgeries better. It's a big procedure to go through, and the easier we can make it with the less complications, the faster patients get home to their family, and the faster they're able to heal and get back to leading a healthy and productive life, an enjoyable life for them, specifically, the patients, for all of our patients, of course, but for those that are in their retirement years who've worked so hard and now all of a sudden they have to go through this horrendous surgery. We just want to make it better for them and better for everybody, but also decreasing costs, decreasing resources, so we can spend those on other things and continue to improve the outcomes. So, and we showed that we can do it as a team together with the vent time. So I know we could do it with this one too. Woo woo.
I agree. I agree. All right.
I am gonna, I know we do have some questions, Nancy, but
Mm-hmm.
just an announcement. Thankfully, we don't have 500 people on this webinar, although it would be nice if we did. But for this announcement, it's a little bit easier now. We have STS Data Manager Facebook page that's gone live late last week. And so I'm going to post the link into the chat box. If you're on Facebook and would like to join the Data Manager Facebook group, it's run by me, Nancy, Emily, Leanne, and please click on this link and join us. It's going to ask you for your PID number, which is your 5-digit participant ID number for adult cardiac. It'll start with a 1 or a 3. It will ask you which database you abstract for, and I think that's it. But just do your best to answer the questions, and we'll approve you as quickly as we can to into the group. But please, it's a place, it's networking, not for clinical questions so much, but networking, sharing ideas. We can really focus on the quality side of things. Um, I think it'll be a lot of great ways to connect with all of you. So here is the link. Well, that's coming. And I am managing that now. So if you see that there, go ahead and paste it into your search bar. And I am on here now and I will approve you. I know most of your names, but if I don't, it'll just take a few seconds for me to double check. So, and we're on there. It's just kind of a fun networking thing. We do have some rules. No clinical questions. We want you to go through the FAQ, of course, for those. Um, no bullying, of course. We're all a nice community. So just be respectful of everybody, of course, and try to keep personal opinions on things that are tricky over, not on this website, not on this web
Mm-hmm.
page. Um, but other than that, we're looking forward to having this available for you all and just really network. And also, if you do have, Melinda's on this call, but Melinda's not on Facebook. So we really try to keep the clinical questions off of the FA. We don't want any clinical questions here. We will remove the clinical questions and send you a response that you need to submit it over to the FAQ mailbox. Um, but other questions that we can help with, we're all on. We check this daily. So please do.
All right. Are we ready for questions?
Uh-huh.
All right. So Hannah's asking about median vent times, that they're more telling when you're dealing with outliers. Yes, Hannah, we have the median times, and I can work on putting something together um, for maybe our next, and I can share that maybe at our next call, on our next webinar. So Deborah asked about the horizontal axis. I'm not sure. The horizontal was time. The vertical axis was vent
Oh yeah,
hours.
we had the horizontal axis at marked at 6, 12, and
Mm,
24 hours. And earlier in our talks when we started this project, we discussed about 6 hours, of course, is the um, it's considered early extubation. And there is evidence to show, studies to support that there are a lot less risk of bad outcomes if patients are extubated within 6 hours. And I think what we heard on one of the talks from Dr. Whitman a while ago is that the bad outcomes double after 12 hours. And you can refer back to his talk. Um, but the bad outcomes double after 12 hours. And the quality metric is the 24 hours, which once a patient's intubated for longer than 24 hours, it's considered prolonged ventilation. And the chances of them having a bad outcome and increased pressure on resources is much higher than at the 12-hour mark. So those were the reasons why we marked those three horizontal lines. It was the 6 hour, the 12-hour, and the 24-hour mark. Of course, for prolonged ventilation, we're looking at, the less than 24-hour mark. But for overall quality improvement of care of patients, we are looking at that 6 hour and the 12-hour mark. And if patients are um, able to get extubated in the OR, there's good outcomes with that as well. So
right. Thanks, Carol.
yeah.
Hannah, I'm gonna unmute you. Or I thought I was. Hannah, you're unmuted if you wanted to talk.
Man, we got a lot of people joining today. I think everybody's on Facebook. And if you want to send me a Nancy friend request, we're very friendly on Facebook.
We are friendly.
We are very friendly on Facebook. And Leanne is too, and Emily. I don't think Leanne's on though. Oh, Leanne is on.
Yeah, I'm here.
Leanne doesn't post a whole lot on Facebook, just her kids
And cat.
and cat and Banks.
And bank and dog.
Yeah.
Hannah, did you want to say something? All right. Let me unmute Amanda. Or Amanda, you can unmute yourself, I think, if you still have a question.
Oh, and I know what else I was going to say. If you have friends on Facebook that you think would be data manager friends or people in the hospital community that you think would benefit from being part of the data manager Facebook group, certainly can invite them.
Sorry, I got
Okay.
my mic to work.
Oh, good.
Um, I'll let you finish that if you can come back to me afterwards.
Oh, you can go ahead.
Oh, okay. Um, I did that North Shore merged with two other hospital systems, and we're looking to get our CV surgery teams to agree to a specific platform and way to develop a dashboard to show everybody's data. And one of the things that I was able to show that if we indicate our median time, it gives a much clearer picture of outcomes, because if you have a large percentage of the patients being extubated less than 6 hours, And to be honest, I know that it's a star rating is related to 24, but if STS doesn't lower that 24-hour mark, it will never go below that. Because it's only when we lowered that expectation, or raised the expectation, sorry, but technically lowered it to be extubated within 6 hours, were we able to decrease our extubation times. So if the expectation, and that's one of the issues we had, because one of the hospitals only looked at 24 extubation, and if you only look at 24 hours, that's what you're going to get. So we had to lower our bar and actually raise it by raising the expectation to 6 hours. And then we reached 6 hours, we lowered it again to 5 hours. So we made it a higher bar in a way because it's harder, but it made people more accountable. And so if STS doesn't lower that 24-hour, it won't change. No matter how much we do, because the hospital systems look at what expectations are.
Yeah, I hear exactly what you're saying, Hannah, and I'll agree. I'll agree with you. I think the part that STS needs to evaluate more is to have data within the STS database to support that there's um, to support a change in the outcomes measure, because right now this is a prolonged ventilation as part of the outcomes measure.
Correct.
And that's where that comes into play at. So we have to have enough data to support the change in getting a new outcomes measure approved and however
Oh,
that
definitely.
works. But I think, the other thing that we can all take responsibility for is for sharing research that shows that the 6 hour mark is where it's at. I mean, we do report out the 6 hour mark as intubated less than 6 hours.
But it's
So
not a star rating. So
yeah, it's not
and
included in the
right. And
star
so a
rating.
lot of
Yeah,
hospitals funding, they can get funding for things that are affect star ratings because
yeah,
star ratings affect Blue Cross Blue Shield Center of Excellence,
yeah,
Leapfrog, all those other things which are monetary. And yes, it improves outcomes and people want to improve outcomes. But remember when door to balloon was at 120 minutes?
yeah,
And it wasn't until they lowered it to 90 and made that the requirement cutoff that things moved. And hospitals invested money to
yeah. And
improve
then
it.
you try to move forward. So we'll have to
Yeah,
talk with our STS leadership. I hear what you're saying and what that all means. So we'll have to,
thank you.
yeah, I think it's a great idea. I think in the interim, though, we need to educate our sites and our surgeons. And the biggest thing is to do the return on investment, looking at financially how decreasing vent times, what that financially means for your hospital. Because I think we know that if there's no financial return on things, despite it, um, eh, if we can't demonstrate the financial return on things, despite that we can show that it improves outcomes for the patients, it's hard to get buy-in. But because of the improved outcomes for the patients, we have to be able to put a monetary value on that, what that means, right?
And
So
it's easier because STS is the only, really the only database that looks at intubation times in that way.
that's right.
And I
Yeah,
think that if you can push that, that's another way, actually, everybody, job security, to
that's right.
make sure that they continue to invest in you guys and us to support
Yeah.
those measures.
So that's right. And so what I would do, I mean, if I was in a position within a healthcare system or within a hospital and I wanted to get a practice to change because I knew that it was something important and I knew that there really was benefit there. I have to prove to somebody that what the benefit is of changing that practice to get the support to put in place. Um, and that would mean showing what if we decreased event times, what does that mean, right? And same thing with blood usage. If we decrease that, what does that mean for the patient? It means that they get out of intensive care sooner. It means that they get off the ventilator sooner. It means that they get out of the hospital sooner. It means that their decrease of pneumonia or any other hospital-acquired infection goes down. It means that they're ambulating sooner, that they can get with rehab sooner. It means that they have less chance of going to a rehab facility, short-term rehab facility, and getting home with their family sooner. And that's the hard part, is putting monetary or doing the research to understand. And I think part of our job at STS is part of our job at STS in the quality area and within the database area for me, Nancy, Leanne, and Melinda, and our other consultants, is to demonstrate and to show you what's out there and what you can provide to help each other with that type of research, why it's important. So I think we're going to focus on that too. And I appreciate that feedback. It's helpful. It's helpful, Hannah. Thanks. That's my soapbox.
All right. Next question from Mary. Why are patients extubated in the OR excluded? And I'm assuming you're talking about excluded from the prolonged ventilation metric. And that would be because prolonged ventilation is measured from OR exit until extubation. And if you're extubated in the OR, there is no vent time to be recorded. Do you have anything to add to that, Carol?
No.
Okay. Next question, Sean. On the first slide of CABG post-op vent hours, what constitutes the x-axis? So those slides were showing the vent time in hours for all the sites. So the x-axis was just every site represented on the slide. Renee asked, will this data be published on the STS website? It will be, the slides and the recording of the webinar will be on our, on the website, yes. And I will update the slides to show the median vent time as well for that. And what percentage of patients are being extubated in the OR? Hannah, I may have that information in some files. I'll have to get that back to you. Okay. Erica says, or asks, in many states, there are significant increases in influenza, which very likely could affect outcomes, especially ventilation lengths. Is anyone tracking things against the trend spikes of new COVID or COVID cases?
Well, that sounds like a great question for our Facebook page.
It does, doesn't it?
I think, yeah, I think I might post it over there too. But if anybody does, we can open the chat box back up and let me do that real fast. Or actually, you can respond in the Q&A.
And also that question brings up, you know, we were talking about how the outcomes tended to decrease across the board at the last quarter of the year. That's when we see a lot of influenza and COVID. So maybe those things did have something to do with the outcomes.
Yeah, that's interesting.
At the end of the year. Yep. All right. Will the overall decrease in prolonged ventilation affect how star ratings are calculated?
No, no.
And may I ask, are you looking at a specific time the blood was given? So we're going to look at intraoperative blood usage and postoperative blood usage. Thank you, Pat, for that question. And then Melissa, I said these efforts would improve star ratings. Can you clarify? Blood product usage is not part of the composite rating score. Is the meaning there will be indirect improvement in outcomes. And yes, your blood product usage is going to indirectly affect the rest of your outcomes, particularly your prolonged ventilation and possibly your renal failure. If your patients are getting a lot of blood, they're, maybe volume overloaded from that and may have increased ventilation time. So yes, it's blood usage indirectly affects your outcomes, even mortality. Jean, can you go back to the slide for the new QI project that starts with kickoff? I will attempt that. What has happened? Here we go. I hope that's the right one. All right. Is there a target for the decrease in blood usage? I don't think we've set a specific target for that, but it should be less than the STS average is what we're shooting for.
Yeah, I think what we'd like to decrease the overall STS average by, I think 5% is a good target within the next year.
Sounds good to me. Carrie, I'll type my email in the chat, or I can go back to that slide for a sec. We'll just do that. Jane Ann, are you looking at all types of blood products or just RBCs? Carol and I talked about this. I'm not sure if we landed on anything yet.
Yeah, I think for the focus of these webinars, we're going to share data on yeah, I don't know. I think we were going to focus on one thing, and maybe that would be isolated cabbages and RBCs. But we can certainly, when you institute blood conservation products, it's likely, maybe other things will get added in as you put these processes in place at your site, to where other products would also be decreased, or your overall management of patients preoperatively will improve to where postoperatively they don't need any type of blood product management done. So it's likely that we may see a decline in everything. We're still deciding on what we're going to focus, but I think we're probably going to focus on RBCs. Nancy and I are still talking about it, though. Right, Nancy?
Discussion. That's right.
Yes.
That's right. Julia had some discussion around how to start targeting your vent times. 6 hours off the bat is hard. Julia would start with 12 hours and possibly work down to 6 hours. Thanks for your comments, Julia. Then wouldn't linking ICU length of stay be a way to correlate cost, as longer intubation times increase ICU length of stay? Yeah, that's possible. It would be interesting to see. I know a lot of other things can increase ICU length of stay, but one of the main ones is certainly prolonged intubation. When the extubated and the OR cases are removed, the prolonged ventilation rates for a site that usually extubates in the OR can look very high because of a very low denominator. And that is true. There's some discussion about, I'm not sure what, Hannah, you mean about these should be picked up with risk data. Then you're looking for any blood usage products. We have a team that looks at this for our hospital system. Our lead perfusionist is on this committee. I will reach out to him. Yes, thank you, Hannah. That would be great. And then there you go, Jean. I think that's the slide you were looking for. And Molly would like to review the IQVIA blood usage reports.
Oh, yeah. Thank
Yeah.
you for that friendly reminder. I know we're at time. I'm busy over here, screwing, goofing off on Facebook. Just kidding. All right, I'm gonna
Get off of Facebook.
yeah, now I have a legal reason or a legitimate reason to be on Facebook during work hours. Thanks, everybody. Just kidding. All right, let me see if I can. So this is our Facebook data manager group. Let's see if we can pull that up very quick here. So for data managers, and I'll go and log into access the database. And because I have not logged into IQVIA, or it's been a week, I have to verify my stuff. As soon as it comes over, there it is. Okay. So on the IQVIA platform, the reports we're going to use to monitor this quality improvement project will be found under the operational reports. And I also think we have total blood product usage here, intra and post-op. This is on the executive summary. It's the first report that pops up. This is just, again, executive summary. It means that it's a very high level review. It's going to show your site. This is static data, meaning that it came from the last analytical report, and it's not changing with each new upload, so it's pretty static. It will update after the next harvest data comes through, which will be the harvest 3 data. But a partial year for 21 and 24, and then full years for 22 and 23. And then the STS is in 2024 in the dark reddish brown color. Again, this is high level, but when we go to, that's the executive summary, so you can see it right when you log in. But what we'll use the most is under operational reports. This link here for the risk adjusted dashboard. We can just select, I'm going to select the most recent harvest, which is harvest 2 of 24, ending through March 30, OR dates of March 31st, 2024. And it's just going to take a second to load. Where we're going to look is in the intra-op section and the post-op section of the benchmarked data. So we have the benchmarked reports here. Right, we got quality ratings, rating trends, the process and outcomes measures, regional risk adjusted and regional outcomes. These are going to be things that are risk adjusted. Blood product is not a risk adjusted outcome, so we don't have observed to expected on it. Risk adjusted outcomes are things that are usually the bad outcomes. So prolonged ventilation, postoperative stroke, new onset postoperative renal failure, death, sternal site infections, and the other thing, return to OR, are the endpoints that are reported under risk adjusted data, but blood usage is not. Benchmarks reports is where we'll find the blood usage for the intraoperative and the postoperative totals. And we're going to focus just on isolated cabbage, so pull that up. It'll have your site's information. You'll see the report, what report we're looking at, March 2024. And so operative is going to have your intraoperative blood usage. Postoperative will have your your postoperative usage, and then a combined total for intra and postoperative, which we refer to as total blood product usage. So this is your isolated operative information. It starts off right away with your blood product use. It's the same report that's on the executive summary, except you can see it a little bit better. And actually, I think we can, I don't know if we drill down in this report or not. Yeah, you can see details. I think we'll show you the details. So, why that's nice. Oh, dang it. Sorry, everybody. Let me get back there. I hit the wrong. I've done that before. Haven't done it in a while on our webinars, but I accidentally hit the back button instead of just hitting the home button. Okay, let's get back to where we were. And hopefully it loads much faster. And if anybody's waiting to get into the Facebook page, I can't do it right now. You're going to have to wait because I'm working. Right, Nancy?
Carol, I'm monitoring it. I've been,
That's
letting
right.
people- I've been approving.
Thanks.
Uh-huh.
Okay, so data analyses, and we're going to go back underneath the operative section. Okay. I shouldn't have hit that back button. I should have hit this benchmark little home button there. Anyway, we have, this is intra-op, so total blood products used, the number of patients who received blood products. Out of those patients, I believe we then, sorry about that. I believe we then report out, um, I have to look at the denominator on this, or the denominator of where we're getting this. I think want to say that this is total patients. So the way I would read this is 27.27% of all of my patients that had an isolated cab in 2022, 27% of those patients received blood products. Then when we break it down into blood products used, this is not looking, it doesn't appear to be looking at the denominator. It doesn't appear to be looking at those that just had blood products. It appears to be looking at the denominator of the whole isolated cabbage population. So I would read this similarly. Of all of the patients that had isolated cabbage, 4.54% of patients had one RBC. 4.54 of those, all cabbage patients had two packed units, and so on. The site probably had a lower denominator, I'm guessing, because these are not changing likely the same number. And then one patient had, or I'm sorry, 9% of my patients had one or more units of FFP. My number here for 2022, and I'm focusing on this because I know it's a full year. Remember when we do the analysis, we're looking at 36 months of data. So it's likely the 36 months of data for Harvest 2 ended with OR dates of March 31st, 2024. So we're going to have January, February, and March in 2024, all of 2023, all of 2022, and then April through December of 2021, because the first 3 months drop off for the leading year, year leading into that analysis period. The first 3 months drop off and are replaced by the first 3 months in the new year added in. So when I look at this, I'm probably going to get a good idea gauging where we're at by looking at the full year's worth of data. And I know in quality improvement projects, we want to look at recent data. So Nancy and I will dive into that further when we go into our next webinar. But to look at where I'm at right now, just to get an idea, do I need to improve? Do I not need to improve? My site improved from 23 to 22. My site improved in 23. We went from 27% down to 24%. And right now in 24, this is 4 months or 3 months, only 3 months worth of data. It's pretty high, but maybe I have a low N. So I'm just going to really pay attention to look at what my like group is doing and what the STS averages. Your like group again is defined by if the number of cases your facility performs, and also if it's has a residency program or not. And then the STS averages all sites within the STS analysis period. So this is in the operative section, this is your intraoperative blood products use. So we'll just remember this number, 27% of all of my isolated cabbages in 2022 received some type of blood product. Now I'm going to hit this benchmark button again. going to go over to the post-operative information, and this is going to be, I'm going to have two sets of blood products reported out here. I'm going to have blood products used and then total blood products. The first section is just related to the post-op period. It's for the section I'm in, post-op information, blood products used. Looks to be 27% of my patients received some type of blood product in the post-operative period. Total blood products used is going to be a combination of intra and post-operative patients. 36.36% of patients of all of my isolated cabbages receive some type of blood product either in the intra or post-operative acute stay phase. When I look at this, looking at my numbers, of course, 2024 is looking higher because it's such a small N. It's only the 3 months worth of data. I'm better at gauging my site's performance by looking at the full years. So 22, 23, 36% and 40% respectively. My light group in 24 was 42%. It's pretty close. My site appears to be performing maybe slightly better than the light group and very slightly better than the STS national average. The one thing I want to find out on this light group for 24 and STS for 24 is if this is only based on 3 months worth of data. I think that it is. Regardless of that, because of the large N, both within the light group and the STS national average, I think we're okay using that data, which is 3 months. 3 months worth. So that's where you're going to find it. Again, that was when you were at the home, you selected the benchmark reports, you went to isolated cabbage, and then you pulled up this, this menu and you found the intraoperative blood products under operative and post-operative and a combined total intra and post-operative blood products under post-operative. That's my spiel.
Very nice.
Nancy, back to you.
Very nice.
I think we're getting close to, we're over time now. So
yeah, we're over time, and I tried to answer most of the questions, typing them in. So I think with that, if no one has anything else, we will call it a day.
And I am going to post the question that we received from Erica. I'm going to post that on the STS Data Manager Facebook page and just see what people think. And Erica, I don't know if you're on Facebook or not, but I can certainly share that feedback with you via email. Okay.
All right. Thanks everybody for joining. Sorry for the wobbly start, but I think it ended up okay. And we will see you again for our monthly webinar, November the 6th.